Urine Microscopics Review Part 1 lecture. So we are going to review all of the microscopic urine parts up to this point. And first, with a urine examination, we do the physical exam first and the chemical exam after the physical exam. And you want to do these two before you would spin down your specimen, so you get the sediment at the bottom. And the reason for that is all the solutes and sediment would not be suspended in the urine, and the dipstick would then be inaccurate. So the procedure graphic, we would need 10 to 12 mLs of well-mixed urine. So if the urine has been sitting, it is important to gently mix it by swirling the urine. We would then put it in a tube and then centrifuge it. And after it is centrifuged, we would get the supernatant, which is the liquid part, and then you have the sediment at the very bottom. We would decant or pipette off the sediment. Decanting means we would pour it off in a real swift, quick motion into the sink, leaving 1 milliliter of sediment for the microscopic exam at the bottom of the tube. At this point, we would add stain to the sediment, and the reason being is that unstained sediment is difficult when using a bright field microscope because of the low refractive index of the urine and the sediment. So we would add a Sternheimer-Malbin stain, and you just need 1 drop, and it is used to differentiate cellular elements such as red blood cells and yeast. Red blood cells will turn a purplish, reddish, pinkish color, and yeast will remain white or yellowish color. Urine microscopy, so we use subdued light, fine focus constantly. We start at low magnification, meaning 10x, and then we go to high magnification, meaning 40x. We usually skim the edges for casts in the beginning of the microscopic exam at 10x. And we do this, and it's important to do the scanning of the slide in a consistent way. Report as an average per field, so we will scan 10 to 15 different fields and we will report the average throughout. And then we will correlate the results with the physical and chemical findings. And we usually think of qualitative versus quantitative, so if there are any at all or how much of it is present. So we start at 10x and we look for mucus. Mucus threads, similar refractive index of hyaline casts, so meaning that it's very transparent in color and can sometimes be hard to be seen. Mucus threads have no clinical significance since they come from the terminal urethra or the vagina. And we report mucus as negative, 1+, 2+, 3+, 4+. If there are a lot of mucus in the microscopic exam, typically urines will appear hazy, or there might be a higher specific gravity. So after scanning for epithelial cells, so squamous epithelials, we then scan the edges on low power field for casts, and these are typically the 2 elements that we look at on high power field. So again, casts can either be straight or curved depending on where they developed in the renal tubules. Formation of casts, the basic structure is a protein matrix. The Tams horseball protein is the main protein present. Plasma proteins may or may not be present, and precipitation of proteins, so they clump together in the tubule, and any material in the tubule at the time of the cast formation will be present. So sometimes there will be cells, red blood cells, white blood cells, fats such as lipids, bacteria, and other inclusions that may be in the renal tubules. Basically, a cast is a biopsy of the renal tubule. That outside lining of the renal tubule is then shed once the casts release from the tubular wall. Formation is enhanced by the presence of plasma proteins, acidic pH, and sufficient concentrations of solutes. So clinical significance, hyaline casts 0 to 2 on a low power field. Normal numbers there are increased numbers during dehydration and physical exercise. Sometimes there are a few granular casts that may be seen that don't indicate any type of disease. There also can be the presence of other types of casts which can be an indication of disease, such as your granular casts, your waxy casts, your red blood cell casts, and your white blood cell casts. Identification characteristics of casts: appearance, even there's a definite outline, so there are very parallel sides, typically longer, and then rounded ends. Except for waxy casts, they can oftentimes have blunt ends and sometimes a crack or a slit in the ends. The cast diameter should be uniform, usually several times longer than it is wide. Sometimes it can be a serpentine or convoluted or folded. Usually it's in a cylinder type shape with tapered ends, and we report these as hyaline casts, which are the most common. Sometimes there can be fragmented or broken casts. Oftentimes waxy casts are typically the ones that we think of when we think of fragmented or broken casts. Usually shaped structures as cells only after. Consider the rest of the sediment and the chemical analysis before reporting unusual shapes or structures. Classification of casts based on morphology and width. So morphology meaning hyaline, granular, or cellular, which cellular includes red blood cells, white blood cells, renal epithelials, bacterial, and other mixed cellular components. Inclusions: fatty, hemosiderin, or crystals sometimes can be included. Pigments, hemoglobin, bilirubin, or myoglobin can be included as part of the pigment. Waxy, sometimes called renal failure casts or broad casts. And then the width or the diameter is also considered, whether it's narrow or broad. And more than one type may be in a single specimen. So there could be a red blood cell cast and a white blood cell cast, depending on the urine sediment and the chemical analysis. Hyaline casts, usually a result of the TAMS horsefall protein precipitation. Large numbers, 20 to 30 per low power field, will be present in severe renal disease. The appearance of hyaline casts are colorless, homogeneous, non-refractile, hardest to visualize, and most least important in small amounts. If a few granules are present, they should still be classified as hyaline. Usually hyaline casts require careful light adjustment with a bright field. It is much easier to see under less light. And steady stain to sometimes stain them a pale purple or pale pink is also helpful in identification. So here's a picture of a hyaline cast again. Cylinder-like with a tapered end typically. Cellular casts, any cells present in the renal tubules when the cast is formed. If in doubt as to the cell type, report as a cellular cast. Other findings in the urinalysis may imply the type of cast, so go back to your physical and chemical findings. And if there are red blood cells present in the chemical findings and you think it might be a red blood cell cast, typically making those correlations will help you determine what type of cast it is. Check to see how many red blood cells, white blood cells, or renal tubular epithelial cells are present. Cellular casts indicate cells within the renal tubule, which is not normal. Appearance: cells make the cast more visible, and proper light adjustment is still important to help with identification. White blood cell casts usually consist of neutrophils. The clinical significance, usually this means there's pyelonephritis. Indicates the origin of the white blood cell is in the kidney. Either it enters through the glomerulus or is a result of an interstitial disease such as an inflammation or type of infection. The appearance, they are typically easy to see, especially if they are stained, because there's a multi-lobed nucleus that helps identify the white blood cells as neutrophils, and this helps identify the casts. They quickly degenerate to the point where it can only be identified as cellular casts and or as a finely granular cast. And sometimes there is what is called a pseudocast, which is a clump of white blood cells adhering to a mucus strand. So you have to be careful and you have to watch for those outer linings of those casts, those parallel lines, to determine whether it's a cast or not. White blood cells like to hang out around mucous membranes because of its stickiness. So, watching for those parallel lines, see the parallel line here. This would be considered a cast, and then you have the white blood cells clumped together inside those linear linings. Here's another example. See the outer lining of the parallel sides and then the white blood cells within them. Red blood cell casts, meaning that there is blood or hemoglobin. Clinical significance, blood may be incorporated anywhere along the nephron. Most red blood cells enter via the glomerulus due to glomerular disease such as acute or chronic glomerulonephritis. The appearance of red blood cell casts are probably the most fragile of all casts found in the sediment. Fresh urine and handled gently are very, very important so they don't break apart. Characteristics, usually it's a yellow-orange color due to the hemoglobin with a bright red field. And here's an example of a red blood cell cast, and then another example of a red blood cell cast where the cells are a little bit more intact. Waxy casts, another important pathological finding, the clinical significance. Often you see along with oval fat bodies or fat globulins associated with nephrotic syndrome. And there's a lot of protein in the urine. Pale, foamy urine typically incorporates waxy casts and is due to the inability to concentrate urine, and it oftentimes has a large amount of proteins. Diabetics with renal degeneration oftentimes will have waxy casts. Toxic nephrosis, such as mercury or ethylene glycol toxicity. And then broad and waxy casts, again, are often called renal failure casts. So here are some pictures of some waxy casts, very blunt edges, and sometimes you will have a crack or a slit at the ends. Pseudocasts and structures confused with casts. Usually these structures are easier to see than casts. Casts generally occur in the presence of proteinuria. So if there's a high protein in the chemical analysis, you might see casts. Some types of pseudocasts, large amounts of amorphous urate crystals, cells and crystals adhering to mucus, clumps of white blood cells, especially in a patient with a severe urinary tract infection, exogenous fibers, mucus or mucus threads, which mucus threads are long ribbon-like strands. They have undefined edges, however, sometimes pointed, splitted, or frayed ends, and will stain a little higher than hyaline casts with the Sternheimer-Malbin stain. Sometimes you will have rolled squamous epithelial cells that will sometimes look like a cast in its tubular appearance. Renal tubular cells, disposable diaper fibers can also sometimes look like casts. Other structures that may look like casts: hair, clothing fibers, threads, scratches on the microscope slide, and the pseudohyphae of yeast or fungi can sometimes be confused with casts.